And welcome to this session this morning, which is a new social contract for Britain's health. I'm Steve Smith. I had the misfortune to be Dean of Medicine at Imperial, and I then was created Imperial College Healthcare NHS Trust, which is I think the biggest one in the country now, where I was Chief Executive. I got out after that as quickly as possible. I don't think there's a single person in this room who wouldn't say that there were difficulties with our health service. I think probably there isn't a single person in this room who wouldn't go a little bit further than that and say that our NHS, I'm afraid, looks to us to be falling apart in front of our eyes. Our NHS is not failing, it's falling apart. And this is something which is far too big for any one or other of the parties. And therefore, a Radix big tent event seems to be the only way that we can go forward. We have to fix this together. But I'm really looking forward to the panel which we've got this morning. So this morning, we've got Lord Andrew Lansley, Andrew's on the phone, Secretary of State for Health 2010 to 2012. Matthew Taylor was previous advisor, I think, to Tony Blair, and is CEO of the NHS Confederation. Professor Kate Pickett is with her this morning, who's Professor of Epidemiology here, and has a particular interest in one of the issues which I'm sure will come up, which is inequality. And last but by no means least, the Right Honourable Richard Burgon. And Richard has had several comments and interventions into the healthcare debate. We're going to stick to the Radix programme, 5 minutes of each person, and then very much throwing it open to yourselves and for further discussion. So without any further ado, and because it's all working at the moment, which is a great relief, I'd like to hand over to Andrew to fire away with your first 5 minutes, Andrew, and your views. Thank you very much, Andrew.
Stephen, thank you very much, and my apologies first for not being able to be with you. I very much enjoyed my time at the Radix Big Tech Festival in Bristol last year. I would like to be with you. I'm sorry it wasn't possible. Not least because I think as many of us who've been policymakers in the past, I think Matthew and I have both been policymakers in the major political parties. The idea of being able to do it in the sunshine and with other people and for it to be fun at the same time, something that wasn't really, I think, vouchsafed to us in years back. A jolly good thing it is too. Let me just say, on this question today, I don't think what we should first focus on is the immediate problems of the NHS, critical though they clearly are, because it would be very easy for us to say there must be more money spent, and clearly there does need to be more money spent. It'd be very easy for us to say that we must recruit lots more staff for the NHS, and that is clearly and obviously necessary for the NHS. But I think what we really have to do at the moment is think about how, in the course of these critical months and years for the NHS, and in the wake of the pandemic and what we learnt from the pandemic, how can we create a more positive prospect for the NHS in the future? And I think in the context of this discussion, that's fundamentally about improving the long-term health of our population, because I think what will come out from the pandemic inquiry, as much as perhaps almost anything else, is that we suffered immensely from the fact that we had poor underlying morbidity in our population that gave rise to significant excess mortality. Now, we can't stop mortality, all of us die, but we can reduce the extent to which we live with ill health. And relative to many other leading economies, we have an awful lot of people who live with chronic illness for a very long time. And what we want to do is to reduce that. Much of it is to do with things like obesity and smoking and general poor health, as well as green spaces and natural environment. Now, when I was Secretary of State, I should say, Steve, I would think much more important in my understanding of the NHS was not being Secretary of State for 2 years. It was being Shadow Secretary of State for 6 years. And I'm sure Richard won't mind me saying that even though the Labour Party have been in opposition for quite a long time, it is an immensely powerful learning experience for the opposition. And I was in opposition for, I think it was 13 years. And as Shadow Secretary of State, that was when people actually told me the truth. When I went around the NHS finding out what was really going on. And I hope that is the case with the Labour Party in the present months leading up to the election. Whether or not they succeed the present government, I think they have an enormous amount that they can bring to the table in terms of thinking about what's really going on in the NHS. But one of the things I want to focus on and start the discussion with is the sense that, if you recall, one of the things that I introduced was the idea that local government should have a public health responsibility. Indeed, for me, central government's first responsibility should be public health, more than simply trying to run the NHS. The NHS, I think, should be relatively independent, be able to run itself. I'll be very interested to see when the inquiry reports to what extent actually politicians thinking that they pulled levers and finding that nothing happened was in fact politicians pulling the wrong levers at the wrong time, in the wrong way. And actually much of what the NHS and indeed Public Health England would have done would perhaps have benefited from less political interference rather than more. But my point was that local government should lead on public health, but that the relationship between local government and the NHS for these purposes is absolutely critical. Most of the things that will improve the population's health are not in the hands of the NHS. They're in the hands of central and local government and local communities. And what we really need to build, the social contract we need to build, is one that is probably accessible and locally led, democratically accountable, and is one which is about delivering improving outcomes for the population in each of our communities around the country. But we have to give a greater degree of autonomy and control to local communities, the local NHS and the local government working together. The latest changes in the NHS have probably distanced the NHS from local government rather than brought them closer together. The health and wellbeing laws, nobody knows now what it is they're intended to do. But there are so many opportunities now. 111 as a mechanism which people should routinely use for identifying what they should do when they have medical problems. The NHS app, the fastest growing app, should be a platform which is working with lots and lots of other technology systems to enable people to manage their own care. The NHS, if it's going to work its way out of the present crisis, is going to need a great deal of public help in terms of self-care, self-help, and identifying and managing their own conditions. And indeed, we need the relationship between the NHS and local government to go to a whole new level. If there's anybody with us today who can speak from experience in Manchester about the success or otherwise of Manchester and the mayors and Andy Burnham's role in health management in Manchester, I think that would be extremely helpful to our discussion, because I think one of the things that on a cross-party basis we should be looking for is that kind of devolution and that kind of local leadership to deliver improvements in population health. And my final point is outcomes. I think the most important thing we did when I was as Secretary of State was to say that what we should focus on is not process targets, but outcomes. And I think we've lost a lot of that. And I think right across population health and our NHS performance, it should be recast to focus on outcomes, not on process targets. I'll leave it there, Stephen, and hand over. Look forward to listening to the panel.
Thank you very much, Andrew. And over to Matthew.
Thank you. So I did my annual talk to our annual conference, Confed Expo, last week, and I suggested a 5-point plan which I thought the health service needs to argue for as we approach the 75th birthday of the NHS. And the 5th point was a new social contract for health. So I shall focus on that, but I just want to mention the other 4 points. I also want to say I think it's a particularly important moment for the health service. It's not just because of the 75th birthday, not because it's important to try to persuade politicians to focus on what matters in the long term and not just a kind of short-term retail offer to the electorate. But most importantly, because we are seeing the beginnings of a revolution in terms of what is available to us as individuals in terms of healthcare. We can find out more about our health, we can monitor our health, we can diagnose our health, we can have access to all sorts of services now being offered by the private sector. And unless the NHS is able to empower and to enable and to use biomedicine technology effectively, then simply the gap between the healthy haves and the unhealthy have-nots will grow. The NHS will become a poor service for poor people. So this is a very important moment. So 5 points, the first four I'm going to go through incredibly quickly. The first thing, and this echoes things that Andrew has said, is we need a health policy, not just an NHS policy. So the NHS is only responsible, generally estimated about 15% of our health outcomes depend on the health care that we receive. The rest is determined by other factors, genetics, social determinants, public health. So we need a health strategy that crosses all the government. We need, first of all, a social care policy until we reform and address the crisis in social care. It's very difficult for the health service to be effective because social care is in even more parlous state than the health system. Then we need not to be afraid of regulating harms. We should be seeking to abolish smoking, in my view, by 2030 or 2035 at the latest, as other countries are starting to commit to do. We need to address the appalling quality of food and nutrition. And then thirdly, we need to address the social determinants of health, all those things like housing, employment, things I'm sure Kate will talk about, inequality and poverty which drive health. So first we need a health strategy, not just an NHS policy. If the NHS is there to pick up the effects of a society that is becoming sicker and poorer, then all it will ever be able to do is crisis manage. The second thing we need to do is investment. I can be very brief about this. We all know the argument for investment. The NHS has not recovered from the 10 years of austerity, which meant it went into COVID in a weakened state, as Andrew has acknowledged. We need consistent revenue funding for the next 10 years. We have to recognise population ageing, rising patient expectations, all drive cost. And some of that is good. You know, the fact that cancer is no longer a death sentence and people want very expensive and quite intensive treatments to keep them alive for many years and maybe even cure them is a great thing, but it costs a lot of money. So we have to recognise that we're going to have to sustain NHS funding at probably about 3.5% above the general rate of growth in the economy for at least the next 10 years and probably longer. Capital investment is a particular problem. We invest half as much in capital investment as other countries, so our hospitals are crumbling, we have fewer scanners, it's very difficult to take advantage of digital. And of course workforce goes without saying, and we are finally going to get a workforce strategy in a couple of weeks. The next thing we need to do is to shift resources upstream. We have been committed to doing this for years and have failed to do it, so we have fewer GPs than we had 10 years ago and many more hospital consultants. We have to try to move our money upstream into primary, to community-based services, into public health. The number one priority for investment in health service right now is absolutely primary care. Primary care is actually a relatively small amount of NHS spending. It's about, depending on what figures you use, it's about 10 or 12 billion out of 170 billion or so. So we've desperately got to rebuild primary care. And then the fourth thing we need to do, which I won't go into in depth because it's an obsession of mine and rather boring to everybody else, but we need to invert the pyramid of the health service. It's far, far, far too centralised. We need a health service which is much more dynamic, and that means one that the centre is strategic and focused. Isabel Hardman's just written a book about the health service in which she concludes the biggest problem for the health service over its entire history has been political interference, and that is still the case. So we need politicians to set strategy, to have focus, then to leave the NHS freer, and then the centre of the NHS needs to devolve to places, to systems, to enable that kind of collaboration Andrew was talking about with local government. And then the final thing, the fifth point, is this new social contract. And at essence, the argument there is that we need to offer more and expect more from people. And if that sounds strange, let's just remember COVID. You know, before COVID, if anybody had said millions of people, the vast majority of the population, apart from one person in particular, will make huge sacrifices for the sake of their own health and other people's health, that the vast majority of the population will undertake diagnostic tests at home and act on those diagnostic tests, people would have thought this was completely balmy. No, the public won't do that. Particularly, you know, the public that's kind of more disadvantaged, less trusting. No, that's not true. We did. We rose to that opportunity, that challenge. And we need to remember that. So many of the things the health service needs to do now rely upon not a model of medical experts handing pills to passive patients, but to a partnership. So things like anticipatory care, when people say, this is how I want my life to end. I don't want to be taken into hospital in the last few months of my life. I want to be cared for at home, or virtual care in people's homes, or patient-initiated follow-up, which is rather than being guaranteed an outpatient appointment whether you need it or not, you are relied upon to make a judgment yourself as to whether you need it, and then you can take it up. So, and of course, the diagnostic revolution, which is going to give us the opportunity to monitor our health throughout our life. All of these things We need to work with the public to design systems that empower people, and particularly empower those furthest away from power, those most disadvantaged, to take control of their health. And that's ultimately got to be our objective. So in my view, if we do those 5 things, if we have a health policy, not just an NHS policy, if we invest in a sustainable way, if we shift resources upstream, if we devolve the health service so we can have effective partnership, place and system level, and if we offer to the public a new deal in which we give them more power in exchange for them being active participants in their health, and there's no reason why the NHS can't once again be one of the best health systems in the world. Thank you.
Thank you very much, Matthew. Very comprehensive. Over to you, Kate.
Thanks. Oh, it's a home audience, which is a tough one, isn't it? I look out and I see lots of faces that I know, which is always really scary. I'm talking about you, among other people. So we were asked to come here today to think about a new social contract for Britain's health. And the question that's posed in this session is, how do we stay healthier longer and reduce the burden on the NHS, which feels like a big responsibility, doesn't it? And for me, as an epidemiologist, as a public health professional, this is a question about prevention. It's about the social determinants of health, which Matthew referenced. It's about changing the conditions in which we're born, in which we grow up, in which we live, and in which we die, so that we're all as healthy as we can be. And for me, this is a really big day to be thinking about these big questions, because I had a new granddaughter born this morning, on 30 this morning. So I almost feel like that was my achievement now. Thinking about how do we create the most healthy environment for her to grow up in. That's what I was thinking about this morning. And actually, this question of how do we stay healthy for longer and reduce the burden on the NHS, it's actually an easy one to answer. We have the science and the social science evidence. The knowledge that we need is already there. We've already gathered it. We understand it. We just can't get people to do the right thing about it. Our health is shaped by our individual factors, our age, our sex, our ethnicity, our genetics, but also by our lifestyles and behaviours, by the communities that we live in, the friends we have, our relationships, our living and working conditions, and all of those are shaped by the general socio-economic, cultural and environmental conditions we live in. Ultimately, that's what shapes our health, and note that word ultimately. In public health, we think about upstream factors, the root causes, the ultimate causes of downstream bad health. And in this context, who's got the ultimate responsibility for prevention and optimization of population health? It's the government, actually. It's the government. Those who've got power over our environments. It's not whether I decide to buy a 2-for-1 ultra-processed meal today, and we heard today that I'm still going to be allowed to do that. It's not whether I do that over choosing a bag of apples. It's about whether or not the government has taken away our freedom to actually make positive life choices, because it's constrained the kinds of environments we live in. It's restricted our choices whilst thinking that somehow it's giving us more freedom. It's hijacked by commercial interests, so choices are poor, and it's hijacked by a neoliberal ideology that says that some kind of weird individual freedom is more important than us having the basic security, the basic equality, the basic context for our lives. Thank you. Yesterday we heard from the COVID inquiry from colleagues of mine, Sir Michael Marmot and Professor Claire Bamborough, that the government was unprepared for thinking about health inequalities and health of the population as it prepared for the pandemic, and that we entered the pandemic with our population health woefully inadequate, and it had got worse over the 10 years of austerity preceding. Life expectancy stalled, infant mortality was rising, our position in a league table of population health, we were slipping over those 10 years. And that wasn't because the government then just didn't do the right things to protect our health. It's because you did the wrong things. You imposed austerity on us and you undermined our public health. All of the accountability for our health is being pushed onto the wrong shoulders. It's being pushed onto ours when it actually is with those who have the power to make the changes to protect our health. So let's make this really simple. We want an excellent health service, and we want a healthy population that's got the least possible need for that service. And the solution to both is luckily the same. Greater socioeconomic equality, a smaller gap between rich and poor, that's the best way that I know of, and other public health professionals and academics know of, to improve population health. Reduce poverty and deprivation, reduce inequality, we will all be healthier. Research within an epidemiological causal framework shows that inequality is a cause of lower life expectancy, higher rates of infant mortality, higher rates of obesity, worse mental health, and better health-related behaviours in more equal societies. And a powerful means of getting a more equal society is through the progressive taxation of wealth and income. And guess what? That also frees up the resources for the excellent, brilliant health treatment service that we all need when we are ill. So that's what a new social contract for health needs to look like. Progressive taxation and more economic democracy delivered by government, and an acceptance and support for that from us. So that's how we can each individually best support a healthy population and a strong national health service, by voting for those who will deliver greater equality and voting for the measures that are needed to achieve that. Thanks.
Thanks, Kate. Richard, over to you.
Thank you very much, and it'd be no surprise that I agree with virtually everything that Matthew and Kate have said, and I agree with much or some of what Andrew said, but obviously he'll be surprised to hear agree with the reforms he made to our NHS back when he was in power, and that leaves us with lots of problems to sort out. 75 years ago, Britain's social contract dramatically changed with the founding of the welfare states, and of course, core to the creation of that was the creation of the National Health Service, a comprehensive service funded by taxation, available to all and free at the time of use. And of course, its founder, Nye Bevan, said that this will lift the shadow from millions of homes, and of course, it did. And we're mindful of that as we approach the 75th anniversary of the founding of our National Health Service. Now, until very recently, the NHS, with its publicly funded universal model, ranked as one of the best in the world for both efficiency and for equity, and the Commonwealth Fund has reported on this. Now, I would argue that's under fundamental attack. I would argue that if we're not careful, we won't have the NHS as we know it by its 85th birthday. We can't allow a situation where a key part of the social contract will be destroyed. So I just want to make 3 quick points today about how I believe we can save the NHS and make that social contract fit for the 21st century. Firstly, I believe we must acknowledge that underfunding is driving this health crisis. The title of the session relates to what are the burdens on our National Health Service. I would say one of the major burdens is unnecessary underfunding of our National Health Service. Reform and technology are often bandied around as silver bullets for the NHS. Now, of course, organisations can always be improved. Of course, technology can be good. But, and to reflect the subtitle of this session, the main burden on the NHS, the main reason for its crisis, in my view, is deep Conservative underfunding since 2010. And the health think tank, the King's Fund, they recently said that we're paying the price for a decade of neglect. Of course, we can't tackle record NHS waiting lists on the cheap. We can't, of course, fill the 140,000 NHS vacancies without paying staff properly, and we can't free up beds filled by people who access social care without investment. And I would say It's not just true that this investment is unaffordable, simply not true. Whatever model is used, we are going to have an ageing society. Whatever model is used, healthcare needs paying for. So the question is whether that's through private insurance, with the poorest, sickest and eldest paying most or missing out, breaking that social contract, or instead do we pursue, as we've heard from Kate, properly progressive taxation, including, which I've argued for, a wealth tax on those with assets over £10 million to help fund a service that helps build social cohesion and helps to build the economy as well. My second point is the need to re-establish the social contract, the need to reassert the key principle of people before profit. Some wrongly argue, in my opinion, that the NHS is so broken that only radical reform of its model away from the public sector can save it. I've heard this in the House of Commons from some Conservative MPs in debates we've had on the National Health Service. I would argue that greater private involvement in healthcare is not a solution, but in fact is damaging, just as it's been damaging for our rivers as well. Look at the United States of America, for example. They actually spend far more of their GDP on health, but have much worse health outcomes and fewer people have access. Greater private involvement is where we're heading without a change of course. Private healthcare providers are delighted that this crisis is driving people to them. As I say, there's Conservative MPs in Parliament openly discussing in debates replacing the current NHS model with the US-style insurance model. And there's talk of more private contracts being handed out as a so-called solution. Tens of billions have leaked out of our health service to private contractors in reforms over the last decade. And those profits, I would argue, should be boosting our NHS, not lining the pockets of the wealthy. So I would say that we need to move back to a model where the NHS is the default provider of health services, because this is the most cost-effective, efficient and socially equitable model. And we need to be mindful of this as we approach the 75th anniversary of our National Health Service. And the third and final point that I want to make is the need for truly preventative interventions to reduce NHS pressures. And that requires tackling inequalities. And this goes back to both points that Kate made and Matthew as well, because most causes of poor health are actually nothing to do with health services, but they are socially determined by the conditions in which people are born, grow, live, work and age in, and the inequities in power, money and resources. And I would argue that this government has hacked away at our social fabric since 2010. Due to austerity, people across the UK are dying younger and are ill for a greater part of their shorter lives. Those in the poorest areas are hardest hit. Growing ill health pressure is a pressure bearing down on the National Health Service. And one shocking statistic, over 300,000 excess deaths in Great Britain are attributed to the government's austerity policies. So tackling socially determined health inequalities means rebuilding, I would argue, the public and social infrastructure. That means ensuring proper housing, means ensuring access to healthy food, ensuring access to properly paid work. And in Parliament, I've been backing a whole host of campaigns around these issues, from a bill on the right to clean air, I'm one of the sponsors of that, to the push for free school meals. And if you just look at the policy push in the campaign for free school meals backed by the National Educational Union, it would generate £1.71 in core benefits for every pound spent on that. And such policies, I would argue, are key to building a healthier society and a healthier economy. We're meeting, and I'll finish on this, at a time when, according to the Marmot report, for the first time since 1900, life expectancy has stalled in this country. The first time since 1900. And it's not just that people's life expectancy has stalled, It's the fact that people, especially poorer people, as we've heard from Matthew, are spending a greater proportion of their shorter lives in ill health. That needs turning round. It can't be done through an underfunded National Health Service. It can't be done through an underfunded wider education system and local government. We need to take a holistic view and ensure that our NHS lasts modernised, but in accordance with its founding principles for the next 75 years.
Well, thank you very much, all of our speakers. And without any further ado, I'm going to throw it open. Can I ask you very, very quickly to ask questions, not statements? And please remember that Andrew is online, and we would like to ask him as well. So please fire away. At the back first, and then here, sir. There's a roving mic.
One of the things I like about these events is the attempt to get views across the spectrum that show the areas where people agree on things. And I think, wouldn't you all agree that one of the things that all parties believe in is that health care from our National Health Service should be free at the point of need to all of us? The question, which I heard the last speaker comment on, about the use of private contractors, for example, in the NHS. It's a subject I've heard, for example, Wes Streeting covering that subject, and it's not unique to any particular party to consider that the way in which we can have free health care at the point of need could be provided by private contractors if they can provide that better. So could I just ask for a comment on what I believe is the fundamental principle that we all agree that we have free health care at the point of need, but how we deliver it is where there is the ability for some debate.
Richard, I think that's for you first.
Well, I'm happy to address that, and I love it when we all agree, but sometimes we're afraid we don't all agree. And I think it goes back to what Matthew said earlier. He referred to the danger of having a poor service for poor people, and what I have heard some Conservative MPs say in Parliament and debates have taken place in is such as the level of crisis in the National Health Service that there should be some kind of taxation incentives for those that go private and lift the burden on the National Health Service. I don't agree with that, because we can all agree that there should be an NHS that's free at the point of use, but free at the point of use in practice for whom? What we don't want, and I think this is what some politicians do want, they want more and more people to opt out of the National Health Service and take insurance if they can afford it, take loans if they can afford it, go private if they can afford it. And that leads, if we're not careful, to something going from mass provision to one day being minority provision. I don't want to see the National Health Services in a few years' time as a kind of safety net. And I think that's why Matthew was right to warn about, we don't want what's seen as a poor service for poor people in relation to the use of the private sector. Now, I referred to austerity in the last, since 2010. The NHS had record levels of satisfaction to the Labour government before then. I make that not as a partisan point, but just as a fact. Obviously, that government used PFI. People like myself on the left of the party aren't particularly enamoured of that, but a lot of resources went into NHS and it improved in every way during that period. But in terms of the use of the private sector as a panacea now, I think we need to remember that most of the time the private sector doesn't have its own staff as such, but they are very often NHS staff working extra days in the private sector. So I think the private sector sometimes needs the NHS, not the other way around.
Thank you, Richard.
Yeah, but I completely agree with your point. The critical issue is that the health care is available to people free at the point of need. Actually, we often talk about the NHS as if it's unique. Actually, the majority of developed world countries have essentially got free universal health care in one form or another, and actually they all have very different mixes of private and public provision. So I don't actually think it's a critical variable. Most of our GPs, of course, are in self-employed businesses. We rely on the pharmaceutical sector, that's private sector. large parts of our community services are provided by the third sector. So I would take a more pragmatic view, I think, than Richard on this. But I also would agree with Richard that when you do use the private sector, you want to make sure you get a good deal. We're pretty good in this country, for example, at screwing the pharmaceutical industry to make sure that we pay a lot less than the Americans, for example, for our drugs. And there have been times, and I would agree on PFI actually, that we have not done a very good deal with the private sector. The particular issue, should you use the private sector to boost capacity? Yes, at certain times Labour did that, and that's one of the reasons we left office meeting all our waiting list targets. So, but Richard's right, in certain parts of the country where there's a chronic shortage of staff, if you expand provision in the private sector, you simply cannibalise those staff and they get paid slightly more work in the private sector. So, I'm as good old Blairite, I take an entirely pragmatic view about this, but I completely agree with you. The critical issue is the founding principles, not necessarily which sector various things are provided by.
Andrew going to be able to respond to that.
If you like. Andrew, would you like to respond?
Thank you. I did want to, much of what I said, Matthew just said about, because actually I think in many ways, we in this respect, we're a European health economy. We believe in universal healthcare and we believe in it funded essentially through national taxation. But of course, in many other European countries, it doesn't mean that they actually own all of the hospitals. Far from it. In many places, they're charitable or social enterprises or local authority. And I suppose I just wanted to quickly insert two points. One is I still haven't heard anybody come back with a role of local government. I'm particularly interested. Kate was talking about the role of government, but I got the impression that Kate was talking about the role of central government. But I actually think when you look at the issues that determine the social determinants of health, many of the social determinants of health are in the hands not only of central government, but of local government and local communities, things like building homes, healthier homes, green spaces, behavioural strategies locally. It's not just national government deciding whether we can buy foods with sugar, fats and salt in them. The other point I wanted to make is in response to, while I have the floor for a second, Matthew was talking, Richard was talking about the Commonwealth Fund. Of course, he was quite right from the point of view of efficiency, effectiveness and equity all the way through to the 2017 Commonwealth Fund analysis. The UK came out top of 11 developed health economies. But actually, of those 11, we came in 10th in each of those analyses for outcomes. That's why I think it's terribly important we focus on outcomes, because if we had paid sufficient attention as a country to the fact that we had an efficient and effective health service, but poor health outcomes, we would have focused and need now to focus on what are the real determinants long-term of health, because otherwise, not only the NHS, but we as a society will suffer tremendously from that lack of good health.
Sure. Of course, public health does sit now with local authorities, and I and many of my colleagues in the room work closely with local authorities and combined authorities here in the north around their health and wellbeing agendas. And we know how good they are at helping to protect the health of the people, but they need money to do that, and they haven't been given enough money, and they haven't been given enough money for a long time. And the areas of the country that got the deepest cuts in local authority spending were those with the worst health and the most poor children. So local authority funding has been handed out in direct negative correlation with need. So yes, local authorities are important for health, and combined authorities and the devolved governments are needing to do more and help us more, but they do need the funding to do that. You can't say it's their responsibility and not fund them adequately to do the job that they are being asked to do.
Next one here.
It's working, right? So I'll get on to my question, but I just want to say, Kate, I entirely agree with you. The thing is, I'm a local councillor in Trafford, and I would say that, we know that half of the council's budget is spent on adult social care. This actually, the funding effectively, we need more central funding from central government to actually pay for that, because otherwise that is actually health and social care go together, and you can't fix one without the other. So that's how that needs to be sorted out. My actual question was going to be, Matthew, so my day job, I work as a scientist in the NHS in Manchester, and what in genetics, and what I found and you're talking about the government not micromanaging, shall we say, with the NHS. It was extremely infuriating in the pandemic early stages with the testing, and we saw it all on the news, and I had to tell my local council, and I normally don't mix my two worlds, but I had to mix my two worlds and tell them that we were stopped. In Manchester Foundation Trust and our genetics laboratory in Northwest Laboratory was stopped doing the COVID testing. We were told not to. We set up and everything for it, and we were not allowed to do it because the contract was given out privately. And what would have much been better, and everyone had agreed, we all agreed, and another laboratory as well, another NHS laboratory, all agreed that actually what would have been better is that money instead had, if it had been invested into the genetic laboratories, the testing was RNA rather than DNA, the rod heads and everything would be there for the future, and which we are going to be doing more RNA, the transcriptome will become the way of future for genetic testing anyway. It would then be actually not just used and gone into the private things that we had little tents doing testing like that. We would actually have had part infrastructure. I'm not saying it would have actually solved the entire testing problem, but I'm saying that I think that would have been long-term thinking rather than short-term thinking, but instead it was micromanaged. How do we stop this happening in future issues come? So how do we stop it?
Well, I'll be really brief so you take our questions, but I mean, what was interesting about the pandemic, of course, is that Simon Stevens, who was then the head of the NHS, he basically wrote to everybody at the beginning of the pandemic and said you need to find your own solutions. And so actually the health service and local government was freed up in many other areas to just get on with it. And that's another bit of learning, I think, from the pandemic. But this question of what you do centrally and what you do locally, it's one of the most kind of intractable issues in public policy. And generally, though, I just the best comment I've ever heard on this is from Jeff Mulgan, who worked with me in Number 10. He said, look, there are some things that are best done centrally and some things that are best done locally, and Whitehall is a conspiracy to make as many things as possible look like they're the former rather than the latter. So all you can kind of hope for is politicians in central government who understand that if you are in central government, you automatically think central government's the answer to everything. And so with people like Wes Treating, one has to keep going on and on about the important role of local government, the partnership, and particularly if we're going to focus on social determinants, those are absolutely determined at local level. If engaging community is important, that's absolutely something that's done at the local level. So you've given one example. There are legion examples. You need the centre, but it needs to be a strategic and focused and consistent and long-term centre. And at the moment, arguably, it's not any of those things really.
They should listen to the genetic laboratories, what we were all saying. The heads of the laboratories were saying.
The centre is better at talking than listening, you may have noticed.
I'm John. Great to see Great Manchester again. And it's on that kind of interlinked stuff, because lots of the levers are definitely connected. This speaks to Andrew's point. So, speaking from the Manchester Homes Partnership, there was two levers that we want to affect health outcomes that we couldn't quite get. So, quick policy question to you is, which one of them would you pull and how would you get it? So the choice would be between unpopular intervention in the housing market or radical intervention in social security, the DWP. So which lever would you pull to affect health and how would you get it?
What's your on that?
I don't want to choose between those. I think we do need both. I think we need interventions in the housing market to address our problems of poor quality, over-expensive housing, of homelessness, of insecure tenure. There's lots of things we need to fix in the housing system that have a direct effect on population health and well-being. But our social security system also does need fixing desperately. It needs more funding, and it needs to get rid of some of the draconian rules that have come in that are not only bad for people financially, but are psychologically really damaging. So I'm sorry, I can't pick between those levers. My point is always that if we tackle the things we need to tackle, like inequality, we free up the resources then through proper progressive taxation of wealth and income to be able to do both of those things and to be able to fix and resource the problems that we have. So I can't pick between your two, what to me are more downstream levers. I want to go further upstream to the fundamentals.
Yeah, to go. So you have really limited political capital. Which do you think had the quickest impact?
Quickest impact? Probably the social security.
I think it's worth just saying very briefly because we have an ailing conservative government and a former Secretary of State, we can kind of attack the right, but it's a challenge for the left. There are interesting arguments for devolving elements of social security. I think the overwhelming reaction of people on the left would be that was highly dangerous because of the potential of undermining kind of universities. And so I think there's a kind of, if Labour does win the next election, one of the issues they'll have to wrestle with, which all Labour governments have to wrestle with, is that the left is no more inherently, a left of central government is no more inherently devolutionary than a right of centre one. So it's an interesting question you raise.
Sorry,
No, I like making unpopular choices. So I've got a choice between you're saying the two unpopular choices. Like Kate, I don't think you can restrict it to those two. I do agree that in terms of the swiftness of a positive outcome, action to boost the money going to people on social security would have the quickest outcome out of the two options that you give. But clearly, there needs to be an intervention into the private rented sector. Clearly, there needs to be a real big council house programme, a building programme, in my opinion, and tenants need more rights, because one thing we haven't mentioned too much in this session, we talked about health as a whole, but we need to ensure that we're talking about mental health as part of that, and people's insecure lifestyles and the uncertainty they face in the world of employment, where it feels very easy to get fired these days, or have your wages cut further when you see the epidemic of fire and rehire going on. People in relation to their insecurity of tenure in the private rented sector and rents going up. These things have a real effect on people's physical but also mental health as well. Obviously, additionally, I back campaigns from the unions to have a £15 an hour minimum wage. The Labour Party passed that policy at its conference the other year. I hope it's in the manifesto at the next election. And we are meeting and reflecting on these issues in relation to the health service at a time where there's been the biggest attack on living standards in living memory. People's wages in real terms are at a lower level than they were before the financial crash back in 2009. And that's the reason for many of the crises we face. That's the reason that people feel so insecure, and that's why we've got this cost of living crisis. And of course, we're meeting at a time as well when there are more food banks in this country than there are branches of McDonald's. And obviously, in a health debate, we're not going to be encouraging people to go to McDonald's, but you get the point that I'm making. That's one of the richest countries on the planet, one of the richest economies, and that's the situation we're in. So we need to look at these levers, I completely agree, and therefore unlock better physical and mental health outcomes, which in of itself will help the NHS deliver the standard of service at the speed which people deserve.
Thank you very much. This lady here.
As I say, I was a GP for nearly 50 years and I'm retired now, so I don't know the normal what's happening fully now. But what I found while I was working was from one government, I've seen many governments come and go, mainly, of course, Labour and Conservative. So when the one government came, a lot of things were sort of demolished for the other person to come and change. This is how we felt at the ground level. And I think, what does the panel feel about having a department which only deals with health, like the Bank of England, which is dealing with money, and the politicians are actually a member of that, and it is sort of funded by the government, of course, and the tax, but the effect of the change of the the waves come, government, Tory and Labour and this and that, and so it doesn't change. It goes on, it does the research there, it talks about the funding, how much tax it needs, and is supported by government.
Yeah, look, I think NHS England was set up to be an arm's length body in order that the government would give it a broad strategy, a set of high-level targets, and leave NHS England to get on with it. Now, arguably, that's not realistic because the public holds national politicians responsible for the NHS in a way that it doesn't hold them responsible for other services that are delivered at a local level. I agree with you, however, in the sense that, I mean, I might not agree with your particular scheme, but I do think that trying to reassert the need for NHS England to have more operational independence and for politicians to, we had a new mandate published just yesterday, and it's fine if you felt that the Secretary of State was going to stick to it and there weren't going to be new priorities piled on top of it. So I think at the moment the idea that you'd ever get to that feels a bit hopeless, but devolving more power to the local level will help because it gives a different form of accountability, a local accountability as well as a national accountability. And I kind of hope that maybe if Labour government is elected, it will recognise that the quality of governance in our country is not a secondary nerdy issue that only concerns people who read constitutions, but actually the quality of government. Our model of change is fundamental problem for us as a country. Central government is in many ways really broken and has to think about doing things in very, very different ways.
Thank you very much. This gentleman here then. Sorry, Andrew, would you like to comment on that?
Yes, please, if I may. Not least the lady GP who was just talking a moment ago. Because one of the things, I mean, I don't want to reach back, it's over a decade ago, but I was, of course, responsible for establishing NHS England. And indeed, for that matter, giving the public health responsibility to local government. And actually, I think the responsibility in local government for public health is an important thing. It should have been properly funded. It was only, I think, in the 2016-17 budget that George Osborne decided that public health and local government were no longer part of the NHS and therefore could be cut and wasn't the beneficiary of the funding commitment that was given to the NHS, modest as that was. And it should have been funded. It should have been better funded. Kate is right about that. And it would have made a significant difference in the intervening years. But I just wanted to return to the point that Matthew was talking about in NHS England. Of course, it was designed to be independent. It isn't actually an immutable law of political nature that politicians must be responsible for what happens in all of the local hospitals around the country. Most of my contemporaries and colleagues in health ministerial office across Europe do not expect to be held responsible in that way. They devote most of their attention to most of the broader public health issues, to the design of the system, the funding of the system, and they spend much more of their time on public health. Not many here, I may be the only person who recalls that actually when we came into office as a coalition government in 2010, I did so off the back of a manifesto that said we were going to create a Department of Public Health and make public health the responsibility of central government in a visible, focused way that it hadn't been because we were going to give the NHS more independence. Those reforms never happened. GPs never really got control, and where they did, they were soon intimidated by the fact that they had declining budgets in real terms rather than rising ones. But actually, the scope for giving the NHS greater independence and the scope for giving devolved responsibility, not for specialised commissioning, but for local commissioning, to health and wellbeing boards and local clinical communities working together with local government, I think they still exist. I think those possibilities are still there. I think the focus on local population health is still best achieved at that level and not by everybody thinking every solution must be delivered by central government. And that the only way in which you can run a health service is by owning all of the means of production in the public sector. Neither of these things are true, and neither of these things happen in other European countries who very, very successfully deliver better outcomes in health than we do.
Thank you, Andrew. We've got 5 minutes, and this will need to be the final question, I'm afraid, starting here.
Thank you. I want to loop back round to the very beginning, where there was a lot of discussion about moving the resource upstream. So keeping people in their own homes for longer, which is something where the voluntary sector, which I represent, can do more. But then you're talking about a lot of more or less invisible services, whether it's the district nurses, the community psychiatric nurses, the domiciliary care providers. Now, my previous experience has been that it's all very well campaigning for them, but the acute hospitals are the ones that get the journalists' attention, therefore they get the politicians' attention. If we really are serious about moving resource upstream in the way that the panel is all seem to want, how on earth are we actually going to make that happen?
Who would like to go on that?
Well, I do three things. Sorry.
First of all, I would encourage the politicians to recognise that the absolute priority for investment now is public health and primary health. So I would challenge that. Secondly, I would give systems and places, the new kind of organising principle for the health service, the objective over a period of time, measurable objective to shift resources, relatively speaking, as they rise. Andrew is right, you can't do this stuff if money's falling, but if money's rising proportionally, that money should be going upstream. And then thirdly, actually, to give you a bit of hope, finish with a bit of hope, I think there's some interesting practice starting to develop at kind of place level, kind of the York, I'm not saying it's happening in York, but York-sized places, where the initial problem that led to coordination, because we now have a more collaborative health service, was stopping people going into hospital, getting them out more quickly. We're now seeing multi-agency, multidisciplinary teams in a kind of war room way, working together, taking calls from the ambulance service, finding alternatives, using virtual care to enable people to be at home, using the third sector, now starting to use data to think, well, how can we actually identify who's most likely to need help next winter and build support for them now? So actually, I think there's already in the health service, because we work in a more collaborative way, there are signs in the best places and systems of a natural move in that direction. And funnily enough, most acute leaders I know don't resist this. They know that the money has got to move, but rather like you, they say, well, given the pressure that we're under, particularly in terms of long elective waits, how on earth can we do this?
Yeah, it's a good final question, really. And I've just got one answer for you, and that is that we need to start doing evidence-based policy making in all areas. We do evidence-based medicine pretty well now in this country. You will not be prescribed a drug unless it's actually gone through a process of decision making about whether it works and whether it's cost effective. And we just need to apply that to the really vast evidence base we have for public health, for social policy and other areas.
Thanks. That's a wonderful question to finish on, because I think there is a natural tendency, we all know how politics and the media and electoral politics works, where the instant attention of politicians of whatever party relates to crises and acute services. And if we're going to end the crisis in our NHS, we can't end it when we're just firefighting, which is what you're talking about, really. We've got to get to the root causes of things. I would say, as I said before, that's ensuring a properly funded National Health Service, so where the funding's not only just going up, but it's going up at least in keeping with the average increase we used to have. So obviously spending is technically going up. The rate at which it's going up is lower than it used to be, and that's at the same time as we've got increasing ill health, an ageing population, and understaffing our NHS as well. But I totally agree with you that we're not going to solve the problem in the NHS if we're just having kind of media-driven firefighting. We need to have a holistic approach, which of course will help to solve the problems you're talking about as well.
Thank you very much. And Andrew, thank you very much for sticking with us. Do you want the final word on that point about primary and secondary care?
Yeah, I mean, I think one of the central issues is about the divide between commissioning and provision in the health service. We seem to have, the management cadre in the NHS has always believed in monopoly, it being the best way to deliver a service. It's not true in most other, in fact, almost any other sector of life. Suddenly we believe it's the case and must be the case in healthcare. But actually, in truth, what we should have, I still believe in it, is a clear divide between those who are responsible for commissioning healthcare and those who are responsible for providing. And I think if you get money into the hands of the commissioners, they can do what Kate was just talking about. They can have what are essentially evidence-based policies for commissioning healthcare services. And as the evidence accumulates that they commission one form, one pathway of care rather than another, and that they focus resources in the community and upstream and primary care and in preventative work to a greater extent than presently, I think the outcomes will demonstrate the value of that. But you need commissioners who are not tied to existing structures of provision. And that's where we are at the moment in the NHS. The providers still rule the roost.
Thank you very much, Andrew. Well, we've come to the end of our time, and it only remains for me on our behalf to thank all the 4 contributors for I think, a really outstanding discussion this morning. Thank you very much.